Moody, consultant adult hematology and bone marrow transplant in National Guard Hospital, Jeddah. Yes, I want to thank Dr. Askar and SSBMT for arranging this webinar. Also, I want to thank our sponsor today, Gilead, for the sponsoring today's webinar. So without further delay, just I need to introduce our speaker today. He's well-known, Dr. Varun Mehra. He's a consultant hematologist as a stem cell transplant and cellular therapy at King's College Hospital, NHS Foundation Trust at UK. Also, he chaired the London School of Pathology Specialist Trainee Committee and represented London Pathology Trainee in Royal College. He has special interest in allogenic stem cell transplantation, intestinal graft versus host disease, opportunistic infection in immunocompromised patient, and hemato-oncology, and stem cell transplant for autoimmune disease. His talk today about fungal management of fungal infection and hematological disease. Okay, Dr. Varun.
Thank you, Dr. Samir. Thank you for that wonderful introduction. So yes. I'll just share my slides and we can then quickly get going. Just let me swap from this. Please let me know if you can see my slides.
Yes, we can see.
We can. Brilliant. Thank you. So yeah, thank you again. So as you've just heard, I'm kind of have any background interest of infections in immunocompromised host as part of my research interest, and I'm a stem cell transplanter working in a large hemato-oncology unit at King's College in London. And we obviously have a very big complex sort of disease areas that we manage in hemato-oncology. And so of course we see a large proportion of these infection patients, which I'm sure you guys are very accustomed to, and then trying to just share across some background data around how to manage these fungal disease in hemato-oncology patients and what sort of new changes that we should be prepared for, and new frontiers really in terms of both the risk factors, diagnostics, and hopefully some treatment aspects that we can cover in this session today. So this is my disclaimer that this has very kindly been sponsored by Gilead. So thank you, Gilead, for inviting me over to give this session to everyone today. And this is my disclosures. And the main thing that we just really need to remember first is, we clearly know infections, mainly around bacterial infections, have been quite a tricky business in our high-risk patient groups, as well as other disease areas, including solid organ transplants, for example, and with antimicrobial resistance becoming a bigger challenge. But in that sort of context, often people forget about the role of fungal infection, which is increasingly becoming more problematic, mainly to the fact that we are using more novel therapies that we have now access for, which is introducing a new kind of aspect of risk to these patients. And that potential increase in that patient risk group means more of these infections will come to light, and then we'll face a barrage of these patients who otherwise were not at risk before. And additionally, the resistance patterns that we are witnessing in fungal management is increasingly quite worrying. And this is where the term superbug is now being used, that often we will face or will eventually come to a point that we'll have very difficult scenarios of managing these fungal infections who are going to be resistant to most of the disease options we'll have. And this is why it's very important to start preparing and approaching these cases in a very focused manner, both from diagnostics as well as early interventions. And then just to kind of highlight to the audience, if they're not familiar in terms of the classification from fungi side of things, we classify them in molds, yeast, dimorphic fungi, but within the hemato-oncology settings, we tend to face majority of times Aspergillus infections or rarely Fusarium infections. The mucor infections are again quite rare and often is an underdiagnosed problem rather than lack of infection. And similarly, Candida infections is also not as common in hemato-oncology settings, and mainly you will see that with line infections as a biofilm formation, for example, or in ITU settings if the patient is admitted there, or post-surgical settings. But mainly in our neutropenic, high-risk immunocompromised patients, you will see Aspergillus infections as predominantly the main problem. And this is just to highlight from a global sort of scale to understand that we are very good in identifying these mucosal endomycosis type infections, which are easily diagnosed. We have good diagnostics tests for them, and we record them in terms of what actually is the incidence of these infections. So we clearly have a much better idea what the global burden of these disease areas are. But come across to the invasive fungal disease elements, we are struggling because we don't know how to diagnose it. Often it's a late or post-mortem diagnosis. And again, the numbers may just be tip of iceberg rather than a true number. So this is definitely a big need to increase that, to decrease that gap between the actual incidence and the estimated sort of incidence that we currently record. And this is important because we then should be able to identify more resources that is needed to help tackle this problem in a true manner. And the reason I'm saying it is important mainly because we have fungal infections around us all the time, in our carpets, in our, in the environment that we live in. And I think we as healthy individuals will be able to fight off any of these spores that may come through our lung epithelial cells, for example. But in the immunocompromised settings, that becomes more challenging. And as the alveolar infection happens with these spores, they start germinating, breaking through the epithelial barriers and making hyphae, and then crossing through the endothelial junctions, which leads to dissemination. And that process of dissemination, which triggers the symptoms of high-grade fevers and becoming increasingly unwell in these patients. And then identifying some of these key aspects of this infective process early on may save some lives. And this is where the whole work is being done in academics and clinical domain for fungal disease, is to try and identify better ways of identifying these infections in an earlier stage by means of biomarkers or molecular methods, and hopefully early intervention or introducing better prevention in high-risk patients. And this leads to the question about the changing paradigm of our invasive fungal disease risk factors. We know classically neutropenic patients are high risk. If you give long-term steroids, they're high risk. And patients who are requiring transplants, for example, or have a graft versus host disease requiring immunosuppression are traditionally the high-risk patient groups. We do know the intermediate risk groups, in terms of other type of disease or chemotherapies, but increasingly this group is being expanded as we are introducing novel therapies to our patients. As you can see, for example, CLL, which traditionally always been a low-risk disease area, but with the introduction of novel therapies like ibrutinib, that risk has increased further, and we'll cover that in a second. Similarly, ICU patients who, for hemato-oncology patients who go to ICU after suffering an influenza infection, for example, are increasingly now recognized as at an intermediate high risk of developing fungal disease. And then we have access to CAR T therapies, checkpoint inhibitors, which are revolutionizing the treatment that we give to these patients in a curative intent in some cases. However, that brings along some very difficult infection challenges for these patients, opportunistic infections, both viral and fungal infections. That is something to watch for. And this is increasingly being recognized in real time or real world practice. So the novel biologics. So clearly we know we're using a lot more drugs that we had before in different disease areas, AML, ALLs, lymphomas, number of new drugs that we are now using. And then clearly there's data around the efficacy of these drugs, but very limited data is around the long-term or infection-related effects. And then, for example, ibrutinib, which originally was a very highly effective drug, but clearly there was a signal coming along in terms of opportunistic infections, disseminated infections, and this early studies suggested that in the first 3 to 6 months of starting ibrutinib, because of effects on your alveolar macrophage functions, as well as T-cell immunomodulation, that leads to further decline in immunosurveillance for fungal disease, and that leads to increasing incidence in the first 6 months or so of starting this treatment. But there is evidence that effect from ibrutinib on the immunosurveillance improves over time. So the first few months of the therapy is the important time to look for any of these new onset infections, especially if somebody is complaining of recurrent fevers, have odd symptoms in terms of, for example, headaches, looking for CNS disease. All of that is quite important to look for and investigate for potential fungal disease. And there is definitely a need for doing prospective studies to understand how we reduce developing these infections and these novel biologics. And the other problems we face is that these novel biologics have interactions with other drugs that we sometimes introduce, especially if you're using azoles. for treatment or prophylaxis purposes. That leads to a variety of different issues, from drug level problems as well as problems with QT intervals, for example. And there is no clear guidance or data to suggest how we best manage those scenarios in terms of what drug levels we should be using, what prophylaxis we should be using, and if we are using prophylaxis, how to reduce the risk of developing cardiac or other toxicities from these additional drug issues that we're facing. In the CAR T settings that I was alluding to earlier, we clearly are quite lucky to have the CAR T therapy accessible in the UK, for example, for lymphomas, ALLs, and now also mantle cell lymphomas. We started to use CAR T cell therapies, which includes a degree of lymphodepletion, but introducing the cells back in again with re-engineered sort of antigen recognition to help kill that tumor. But that leads to significant period of aplasia, neutropenia, lymphopenia, and that clearly is now being identified as a risk period for developing a variety of different infections, which traditionally from a disease aspect wasn't the case. So clearly the therapy-related changes that we're now seeing in our host immune system are leading on to more difficult infections. And then we have seen mortality as well as severe morbidity because of disseminated fungal disease or viral infections in our group of patients. And then you can see that if you have higher CRS developed from these CAR T therapies, which is a common side effect we see, you often have to give them steroids or tocilizumab. That leads to further risk of immunosuppression and more risk of fungal disease. And this is what this 3.4 hazard ratio is suggested, that it increases your risk by 3 times if you have a higher CRS. So that's something, again, to be aware of in terms of where we are with these infections. And I think if you look at the phases of CAR T related therapies, it follows the same sort of trend as an allogeneic transplant patients, in which you are seeing a number of these viral and bacterial infections, as well as late stage fungal infections in some of these patients in the first 2 to 3 months of their transplant. And that is a worrying sign and clearly under-recognized problem. And we are trying prospectively to understand how we can better diagnose these infections in these high-risk period for CAR T infections. What about other risk factors? For example, baseline CT, how does it matter? There's clearly a lot of talk around baseline CTs more recently. We have done some work showing a few years ago, suggesting that if you had abnormal baseline CT at the time of starting induction chemotherapy or stem cell transplants, having an abnormal scan of any kind did lead to a higher probability of developing invasive fungal disease. And if you had URTC-defined changes at that abnormal scan at baseline, your risk was 3 times more than the baseline. And that clearly was a worrying trend, and more studies have been done since, but more or less in heterogeneous settings. We did another study we recently published, or presented in our British Thoracic Society meeting a month ago, showing a large allogenic stem cell program for around 350 transplants that we did, and looking at baseline CTs in all of them, which was we started doing prospective baseline CT in all these patients, and we identified that if you developed, if you had an abnormal baseline CT, the risk of you developing fungal disease was significantly higher, which is in terms of if you had ARTC changes, your risk was 54%, it was 91% versus, IFT-free survival was 91% if you had normal CT, but only 54% if you had ERTC-defined changes. And that led to further decline in survival if you develop fungal disease post-transplant. So clearly we identified some high-risk individuals who may develop abnormal baseline CT, would then have a subsequent risk of developing fungal disease, and focusing on these patients at an early stage before we hit them with immunosuppressive therapy to help optimize their lung functions, investigate more effectively risk of any presence of fungal disease at the outset, and treating them more aggressively before they get more immunosuppressed. And that might improve their survival and hopefully better outcomes for these patients. And we know with this pandemic, we have coronavirus, and that has been associated in the past with different type of coronavirus and fungal disease. And more recently, the reports, including our group, have reported coronavirus or SARS-CoV-2 related invasive aspergillosis infection. We call it CAPA or Kappa infections. And this is the diagnostic algorithm we proposed in a publication last year when the pandemic was just starting, and we were starting to see all these fungal disease in our coronavirus positive patients. And this involves mainly doing a number of different biomarkers in different samples, BAL, trached aspirates, to try and identify these patients early, and then considering antifungal therapy depending on the risk factors as well as clinical worsening of these patients. So that leads on to the fungal diagnostics element of this talk now, because we identified clearly there are new risk factors that we have to worry about, but at the same time, our diagnostics probably are not really there yet. We are still stuck in many centers doing culture-based or microscopy-based methods, and often that relies on you identifying an isolate first, and then confirming the infection. And that often is a very late diagnosis of these fungal infection. They already are disseminated. And if you're growing a fungus in a petri dish from any host sample, that often means it's too late and then is widely disseminated infection. So clearly there is efforts to identify them at an early stage using antigen methods, for example, galactoman and beta-glucan. Lateral flow devices are coming along now. We have been working on gliotoxin-based method to try and improve sensitivity of these methods to help an early diagnosis. PCR is now being included in one of the standard sort of criteria identified by EORTC, which was only recently revised. That now becomes a standard part of doing investigation for fungal disease. And we have radiological methods, of course, which is again very subjective in terms of who your radiologist is and when the scans are being done. And additionally, we need to identify that we certainly have to start thinking about doing therapeutic drug monitoring for our antifungal drugs, especially azoles, which obviously for purposes of knowing are they under therapeutic and that's the reason for their breakthrough infection, or they are still therapeutic and possibly reflect a resistance from azoles that leading to breakthrough infection. And that is an important question to ask, because that will dictate how you would treat that fungal disease by either a similar class of drug or a class switch, depending on the risk we see from a fungal resistance. And that means we also need to have access to azole resistance screening, especially in molecular methods, because isolate positivity is quite low still in our hem-onc settings. So PCR methods with azole resistance screening is probably the future to try and identify these patients early. And it's important to highlight that biomarkers are not really the best way to monitor these patients, often because if you're using prophylaxis, your sensitivity drops down significantly by a third. For example, here, if you're using azoles, and the galactoman can often be falsely negative, which is of course is a worry. Then you do miss out some patients because of that reason, and also these tests is only significant in neutropenic patients only. So non-neutropenic patients may not necessarily have a good rate for positivity in these infections, especially people like coronavirus or COVID-19 infections or CAR-T infections, for example. That brings along, what about the radiology? We do know the halo sign, for example, was a prime example that was picked up many years ago, and this study published for the first time describing in 1985 halo sign as a pathognomic sign for potential fungal disease. But we know since then this sort of picture can be seen in other infections, including things like Kaposi's sarcoma and angiosarcoma, which can look similar to a fungal disease, but actually they're not. And that leads to this poor sensitivity of these signs that we often think are classical signs, but may not necessarily be invasive fungal disease. And then that means doing more invasive biopsies or other methods that to try and identify what these lesions may mean, which is very important to direct the therapy in the right context. EORTC sat down back in 2002 and then again revised the guidelines in 2008 to look through all these issues about the diagnostics issues, the type of risk factors patients have, the clinical features, to try and put together possibility of defining the fungal disease better, especially to try and help do clinical trials in a more structured manner. And that identified, again, this was revised just in 2019, late 2019, showing that if you have the right host with all these risk factors, which I've just covered, with the clinical radiological features, which often are EORTC defined changes, and of course with mycological tests additionally, you probably will have a confidence to call this as a probable invasive fungal disease. And that mycological tests have had new thresholds been suggested with galactoman, and now more than one optical density being classed as positive, or if you use BAL, you can have 0.7 and above as positive, for example, which is different to what you have been using in the past. Similarly, aspergillus PCR is now an important part of this exercise to try and help get more confirmation of what type of fungal disease it is. But again, this is not that will prove fungal disease. This is at best will show it as a probable fungal disease. But you ought to have all these elements before we can safely call this as a likely, more likely definite sort of fungal disease that we're treating. But that brings on to another problem, because if you were to wait for those ERTC defined criteria to be applied, often that is quite late still, because we do know fungal burden increases by that time and dissemination process is already happening. So we do need to kind of find better ways from a diagnostics front to preemptively screen, or a targeted screening approach, that we try and pick up these infections and then aggressively intervene as soon as there is any signal, both clinically or from biomarkers point of view, rather than waiting for all the changes to appear for an ERTC defined criteria, for example. And that's is probably the way forward. And I think combining diagnostic tests, as we've shown a few years ago from our group, that if you were to use only one diagnostics test, your incidence rate was just 11% in those patients. But in the same patients, if you were to apply combined diagnostic methods, your incidence rate went up to 21%, which is more real life, I would say, because if you look at postmortem series, they're still diagnosing around 19 to 20% of patients postmortem, which are often missed because of lack of diagnostics or only single diagnostics. So clearly, we are seeing more real-time incidence rates that hopefully, with using the better diagnostics, will allow us to intervene early. And that's important because we did see these patients who did have fungal disease eventually had a poor outcome from a survival point of view. So anything we can do to improve the diagnostics beforehand, before they start becoming disseminated or mobility-wise more worse, we might be able to save more lives. And that requires really a dedicated approach from our laboratory services, our ID services, and some sort of targeted screening approach, or even prophylaxis approach in these patients to reduce these fungal disease patients. So let's just talk quickly, probably a bit more detail, I would say, in therapeutics domain, in terms of how we really are today managing these infections. And sadly, we only still have 3 classes of drugs available to us, although the list of these drugs are expanding over time. And we have polyenes, including liposomal formulation, for example, with Ambisome. We have azoles, which is clearly been the more heavily sort of domain where we have more drugs being added on a regular basis, recently being isavuconazole, for example, and we have echinocandins. It's also important to know between these class of drugs, the spectrum of activity against a variety of clinically significant pathogens that we see in our patients, for example, Candida infections, Aspergillus infections, mucorales, Fusarium. And we could see, if you look at Ambisome, it has fairly a good degree of spectrum across all infections, including Fusarium and Scerosporium, and even Candida and Ambisome and Aspergillus infection. But if you look at the caspofungin or echinocandins per se, the spectrum of activity is limited mainly to Candida-like infections and very little to Aspergillus and none to mucorales type infection. Within the azoles, we do know that triazoles, especially the posaconazole and isavuconazole, are quite strong in terms of broad spectrum of activity. Voriconazole does suffer a little bit in mucorales cover, and then again, the fluconazole, itaconazole are basically not as a broad spectrum as we think. So clearly, we have limited choice of drugs that we can potentially use in these patients with that broad spectrum of activity, especially if we don't know what we're treating. And that brings to the question, how are we going to strategize to manage these infections? Are we going to give prophylaxis to all patients that comes to the door and just hope that they won't develop an infection? If they do, we treat. And that leads on to the empirical approach that you kind of wait for fevers. And if the fever is persistent, you add in antifungals and hope it'll get better. But that may mean you're over-treating in many cases, because that may not be a fungal disease or something else altogether. Or you wait for diagnostics to be coming first, which means preemptive approach, which often can means you're missing patients and not treating them early enough. And that creates a bit of a dilemma in terms of which strategy is better than the other. And that really depends on the type of patients you have in your center, the epidemiology that you see, the type of diagnostics you have access to in a timely bound manner that will allow you to have either targeted diagnostics screening approach, plus minus prophylaxis, or a preemptive approach whatsoever. But I think we do need to move away from treating everyone to more targeted approach in the coming future, because that will save more lives and reduce risk of toxicity as well as resistance issues. And if you look at the data around empirical therapy, for example, a lot of studies have been published, but mainly in the last 20 years or before only, nothing more recently in the empirical settings. And I think one study that I'd like to highlight was done in a randomized fashion between a liposomal formulation of AmBisome and voriconazole for empirical approach, meaning only fever-driven approach. And that showed a composite equivalence, suggesting that voriconazole was equivalent to AmBisome in terms of efficacy. However, this is a bit questionable in my mind, mainly because if you look at the response criteria to these therapies, there was clearly positivity for AmBisome in all domains, including domains like survival, fever resolution, baseline fungal response. But the only place where voriconazole was highlighted as superior was in reducing risk of breakthrough infections. But if you look at the further critique that was published through FDA even and Cochrane reviews, the study overall failed to meet the defined endpoints. So clearly we cannot rely on the outcomes of this study to say voriconazole was equivalent to AmBisome, for example, in this setting. And even the low rates of breakthrough infection with voriconazole arm was seemingly misquoted based on the definitions they used. And this is was published as a critique a few years after. But because of that sort of high marketing that was done at the time, voriconazole was thought to be quite effective in managing patients with empirical approach, and that still is what is being practiced in many centers. But if you look at liposomal versus the conventional amphotericin formulations, for example, we know now that clearly liposomal formulations are better tolerated, they have less toxicity, and maybe probably because of that, they have better efficacy because patients can take them for longer, and that overall reduces the risk of fungal disease, related mortality, and morbidity for these patients. So clearly, liposomal formulation seems to be superior in terms of tolerance and possibly efficacious at the same time. But the dose effect, for example, 3 versus 10 milligram has always been questioned, or high doses versus low doses. But generally speaking, 3 milligram per kilogram dose is quite effective, and you do not necessarily need to give higher doses for these patients unless they have disseminated sort of CNS infections or infections like mucor or fusarium-like infections, where you may need to increase the dose to these patients. But 3 mg per kilogram is generally quite effective, and you're only adding toxicities otherwise if you're using higher dose. In terms of other agents like caspofungin, this was a randomized study, again in empirical approaches, that was published back in 2004, again many years ago now. This was a large study, 1,100 patients that they picked up, and it was shown that caspofungin was equally as efficacious as the liposomal formulation with a similar overall response. However, if you look in details, majority of the patients used in the study was from a low-risk background like autografts or lymphomas, which are not traditionally known to have a higher risk of fungal disease, and then clearly did not really suggest it was a real-life settings that we normally see in high-risk population. That led to further recommendations from IDSA, for example, that suggested echinocandins are not effective, are effective only in salvage therapy, but not as a routine monotherapy of invasive aspergillosis. And similarly, prime therapy is not recommended and can only be used when azole or choline antifungals are contraindicated. So we use echinocandins as a second-line approach in our patient groups rather than first line in the empirical settings. If you look at what is the best way to manage these patients, empirical or preemptive, for example, should we wait for diagnostics or should we keep doing fever-driven approach? And this again was a study published about 10, 11 years ago, which looked at in a randomized fashion between empirical and preemptive approach. Overall, both strategies did not kill more patients. Overall survival was similar. However, there was definitely an increased incidence of proven and probable infections in the preemptive approach, meaning we were missing out on many patients by waiting more, which means more morbidity. And for that reason, that meant most of the centers stuck to the empirical approach to try and reduce risk of proven disease and manage these patients sooner, because overall efficacy, overall survival was similar. But that did lead to more antifungal use and more toxicity risk at the same time. So clearly not ideal, but that was the safest thing to think at the time. What if, in terms of the treatment approaches, where we do have evidence of probable or proven disease rather than an empirical approach where we don't? This study, voriconazole versus amphotericin, conventional form of amphotericin, was looked at a few years ago, 20 years ago again, which is a randomized study and was the landmark study for voriconazole, because that led to strong recommendations for using voriconazole in treatment settings based on the fact that it had a clear survival signal compared to the conventional amphotericin B. However, this is again not directly compared to liposomal formulation, just the conventional form. And within that study itself, there was a couple of strong critiques published, again, a few years later by Cochrane and others, who clearly argued about the study's flawed design, because clearly the study investigators ruled that any patients who developed renal dysfunction or electrolyte problems had to come off the study on the amphotericin arm, which was not the case with the voriconazole. So clearly the median number of days patients were on voriconazole was 77 versus 10 days of amphotericin therapy, which meant more patients were on longer term of antifungal treatment, which clearly meant they would have definitely survived longer, versus those patients who had to unfortunately stop amphotericin, and there was no crossover allowed, which meant voriconazole was going to be a winner in any case because of that study design. Which again brings to the question, there is no, again, comparative data with liposomal formulations. It's difficult to say if that is still the case with voriconazole. The isoconazole is the new kid on the block, which again was studied in the last few years, and studies published 2 years ago, the SECURE study, which looked when randomized to voriconazole for treatment approaches, clearly showed that it was non-inferior to voriconazole and was better tolerated than voriconazole, did not require drug levels. And that led to very quickly grade 1A grading on the ECIL-6 guidelines, suggesting it can be used as first line for invasive aspergillosis treatment as an option, which is quite good because we do need some drugs like this which are less toxic. And then again, the isoconazole itself has not been directly compared against liposomal formulation of amphotericin. And more recently, hot off the press, this study was published just about a month ago, looking at posaconazole versus voriconazole for primary treatment, phase 3 randomized study. And that clearly showed that posaconazole was non-inferior to voriconazole in the treatment settings. And again, posaconazole was better tolerated and fewer treatment-related side effects, suggesting that overall, we have now better options for treatment in azole settings, mainly posaconazole or isoconazole, and voriconazole may just be a drug that can be used for some more specific scenarios, especially with CNS disease, for example, where it has a better CNS penetration, and may mean voriconazole may lose that sort of favor that it always had in terms of the azole choices that we may have to make. And this is where we kind of are in terms of with the evidence we have for treatment of invasive aspergillosis. We basically have 6 options. Either we stick to our amphotericin or liposomal formulations, or azoles, which I've just covered with echinocandins. And this is mainly based on just 4 or 5 randomized studies more recently with the posaconazole one, which I've just added in here. But majority of the data is mainly around observational studies or have no data whatsoever, especially if you want to look at comparison between liposomal formulation with echinocandins or voriconazole or isoconazole for that matter. So clearly, any choice you make about how you treat these infections will depend on the overall algorithm you have in your center, based on your risk profile, based on your diagnostics that you have available, and the type of drugs that you have, and the confidence you have with these drugs. And again, you have to look into the resistance epidemiology at the same time before you choose one drug over the other. We tend to choose from a class switch option that we have an azole prophylaxis. We tend to do a class switch when we have to treat these patients. And of course, if we have better TDMs available, we tend to stick to the same class if we know there is a subtherapeutic element involved. And this is where the ECIL-6 sits. At present, we are hoping to revise this guidelines this year. I'm part of the study group doing that, and we'll hopefully come up with some better recommendations. The voriconazole and isoconazole is sitting at A1 grading, as I just explained, and liposomal has a B1 grading, again, based on the fact there is no direct comparative data, but still the efficacy is quite strong with the drugs. In terms of candidiasis, any echinocandins is good. So you can choose micafungin, caspofungin, but the caspofungin is still used as a C2 grading in the aspergillus treatment option. In terms of the timelines of all these drugs, we know it's been a slow starter in the early 60s, but in the last decade or two, we have had an explosion of number of new drugs, including mainly around echinocandins and azoles. But that also means these drugs have been heavily introduced in agriculture and environmental or industries that we have around us that is heavily using them, which means more resistance is now being identified with the drugs used. So clearly there has to be some sort of regulation in terms of any new drugs being introduced for clinical use and not making its way to agriculture or industrial use straight away. There has to be some degree of control that needs to be exercised to reduce that risk of resistance patterns. But we are lucky that we hopefully will have some new drugs come along in the market. There are a couple of new class of drugs that we now know of that are in advanced studies. I'm doing a couple of studies in the UK, mainly around once weekly kind of kinase like risafungin. But I'm excited about fosmanogepix, which is a drug which has a broad spectrum of cover for both azole resistance as well as complex infection. The erotomide inhibitors, for example, are primarily going to be important for azole resistance type Aspergillus infection or mucor infections with Fusarium, for example. So that is some space to watch, and hopefully we'll have these drugs become available for these really sick, complex patients. That brings on to my final few points around that this knowledge around knowing more better about how human fungal pathogenesis happens, the interactions between host immune system and the fungal microbiome, as we call it, interaction, we have better understanding, but we still do not have the typical tracing markers, as we say, to try and identify those infections early. We do have access to better drugs. We do know that we have more patients at risk who may develop fungal disease, but we also have to keep in mind how we treat them in terms of cost effectiveness, that we're not over treating them or using too many drugs. And again, at the same point, looking at resistance patterns in our community to understand that we don't end up introducing more resistance in clinical settings. And this is the azole resistance world map, which you may have seen before, which is in red here, suggesting that this is definitely affected a large part of many countries in the Western world, as well as in Southeast Asia and Americas. The white ones are where we don't have data for yet, but I'm sure there'll be azole resistance already in place in these areas, again, with heavy environmental agriculture use of azoles. And just kind of giving you this continuum of empirical therapy that we have to balance between late diagnosis and early diagnosis, but often at the same time treating at the right time to avoid additional morbidity, because if you do it too late, they often are not responding to these fungal agents. If you do it too early, they often are overtreated and have toxicity risk and resistance risk. So all of that balance needs to be equated in terms of how we have diagnostics, the type of risk patterns we have, and then the drugs we currently use. And this is the algorithm that we have at King's, in which we basically use biomarker screening. Still, we use post-conazole prophylaxis for all our high-risk patients, but we also do biomarker screening, mainly for the fact that even though we know the sensitivities are lower, we do think if they are truly positive, that is quite likely to be invasive fungal disease, and then we treat quite aggressively. Of course, if they are continuously negative, we do also add additional diagnostics to try and pick up these infections, even if the biomarkers are negative. And we do baseline CTs in all of these patients. And if they're persistently febrile, we request a CT chest. We send off therapeutic drug monitoring for the azoles at the same time. If there are classical signs on the CT, we treat. Our first line is ambisome in this setting because it's a class switch. Of course, if TDMs come back as under therapeutic, we tend to then do consider going back to an azole again. In that setting, it could be an isoflurconazole or even voriconazole, depending on the type of infection. If you have non-specific change in the CT, we also request for bronchoscopies, which we also do in both settings, where we do have classical signs to have a better pickup rate. And once the bronchoscopy is done, which we are very lucky, we have a very kind of closely linked respiratory team, radiology team, who help us get these investigations done quite promptly within a few days of requesting. And in the meantime, we treat them with ambisome, but we, of course, relook at the results of the diagnosis and direct treatment accordingly. More importantly, if you have negative CT and negative biomarkers, we do not change treatment. We carry on with prophylaxis and still keep looking for other source of infections. Of course, if you have normal CT, but a positive biomarker coming along, which could well be a false positive, but we do treat for that 1 week, repeat the CTs as well as the biomarkers, and if they come back as negative, then we stop and go back to prophylaxis. And that's how we've been running our sort of stewardship model to try and reduce patients who require antifungal use. We are doing weekly antifungal MDT meetings jointly with the ID team, respiratory team, radiologist, sitting down weekly to look at all patients we have in hem-onc wards undergoing fungal therapy and making sure they're adhering to our policies, as well as giving advice in terms of how and when we should be treating these infections and to consider stopping therapies when is appropriate. And that has been quite helpful because that's a two-way dialogue that we have with our clinical teams who are attending on the wards, my colleagues in the hem-onc settings, to improve education of the juniors that are involved, to help optimize the antifungal management in a more structured manner and evidence-based manner rather than just empirical approach that we always have been doing so far. And with that, I end my session. I'll take any questions. Thank you for listening.
Thanks, Dr. Varun. That was informative to cover like a big challenge, I think, for all physician who's treating hematological malignancy or stem cell transplant. So I think we can start now with the Q&A session. But just I will suggest from the attendees just to type your question in Q&A box. So I have two questions. So start my first question. So it's written, the common challenge in using antifungal is the drug-drug interaction. Yeah. Do you see this being advantage for the AMFO?
I think that is probably right, because as I said, in my slides earlier, the azole interaction with a number of different drugs is quite challenging. And I think, not saying that amphotericin doesn't, clearly the renal toxicity risk often has to be addressed. But azole challenges definitely means that if we do start, for example, somebody on midostaurin for acute myeloid leukemia problems, for example, then you really have to worry about how we're going to cover that fungal risk, because we do know the QT interval issues is a problem. We don't want to undertreat with midostaurin by dose reduction, or we don't want to give low doses of azole prophylaxis, for example. So we often end up giving them ambisome during the time of the neutropenic phase of the infections. And once the counts have recovered, then we switch them over to an azole at that time. But that is still a challenge, because giving ambisome to some of these patients who may well be treated as an outpatient means they have to be hospitalized or kept in the hospital, or keep bringing to hospital to keep giving these ambisome in a prophylaxis manner, which is obviously an unlicensed indication in this scenario, which is an increased burden. And I'm doing a study in our center looking prospectively in patients who are going through this novel biologics and looking at azole levels and biologics drugs levels, and understanding the interaction between the two, and identifying the possible middle ground that we might be able to have, and then seeing if our worries are correct, that they do interact with the drug levels and has potential risk for toxicities, then we may have to forego using azoles as prophylaxis in these patients, or consider approaching as a targeted sort of preemptive approach, that we enhance our diagnostic screening for these patients without giving any prophylaxis. And the moment you have any signs of positivity or clinical fever suspicion, you treat at that time rather than having to give ambisome. And I think a couple of centers in the UK are doing that. They just use diagnostic strategy rather than a prophylaxis strategy in these settings. But ambisome clearly, does help in these scenarios, that you don't have to then worry about interactions, and you could safely use it while the patients are in the hospital. But the outpatient management becomes very challenging in these settings. Yeah.
Okay. One of the other questions, do you recommend antifungal prophylaxis in severe cyclic neutropenia?
Yeah, so that's interesting. So I think generally not, I would say, because clearly that cyclical neutropenia is not really underlying bone marrow failure as such, and most of these patients don't necessarily present with fungal disease. From our experience, we had a large bone marrow failure service, and we see a number of cyclical neutropenias being referred to us. So we don't necessarily use antifungal prophylaxis in these patients, if they are, for a period of time neutropenic for a few days, for example. We do suggest, especially in the severe settings, giving them antibiotic prophylaxis for that period of time at the high-risk period. But generally speaking, the risk or epidemiology for fungal disease is not high in these patients. So I would not recommend prophylaxis.
Okay. Right. As I mentioned earlier, some patients like CLL, they already have hypogammaglobulinemia, the risk for infection. Introducing BTK inhibitors will make the risk is higher. So in case of the patient already is CLL on BTK inhibitors and he developed invasive aspergillus fungal infection, would you consider this like absolute contraindication to assume ibrutinib or any BTK inhibitors, or you will you will restart again once the patient infection is improved?
I think this very much points to the fact that a number of studies have looked at this area more from immunomodulation properties of ibrutinib and how time-dependent changes happen in the patient immune system. And I think the first 3 to 6 months is when the risk is highest. And I think following that time, by 9 months to a 12-month period, there is clear evidence both in mouse models as well as human sort of studies that the T cell function improves, the macrophage suppression that we see in these patients in the early stages of ibrutinib also improves. So that does mean that the risk of developing these opportunistic nasty infections reduces over time with ibrutinib. So even if you do develop some sort of fungal disease with hypogammaglobulinemic type patients on ibrutinib, you clearly have to treat that first and hold ibrutinib until that is treated. Then you have to kind of look if there are any other options available for that patient in terms of CLL management for additional few months, if possible. If there isn't any, then you could potentially start them on ibrutinib with some prophylaxis at that time to try and wait for that improvement in immunocompromised sort of immune surveillance status. So that's what we normally use. If there is no other option available, we don't have any other access to the drugs, we give them prophylaxis for a few additional months during that risk period. And of course, if they keep having recurrent infections, that prophylaxis may have to be extended, or they may have to come off the ibrutinib altogether. And that is rare, but can be still challenging.
Okay. Would you recommend the primary prophylaxis for patients CLL on BTK inhibitors?
I think that is a good question. Studies are being done. One of the studies that was being done unfortunately failed because, again, the incidence was not thought to be high. You need quite a large population on ibrutinib to go through. Still the risk is around 3 to 5% of developing invasive fungal disease in patients with IFD, which traditionally was less than 2% in CLL settings. And anybody who has 7 to 8% or more risk is thought to be a high risk setting for giving prophylaxis or considering prophylaxis. I think it's sitting in the middle. That's why I've classed it as intermediate risk. So you wouldn't necessarily give prophylaxis to all patients, but you would give it for somebody who have had previous fungal disease, are older patients, or have severe hypogammaglobulinemia, and you require ibrutinib therapy, and that you would need to consider prophylaxis for these patients, at least for the first 6 to 8 months of the therapy.
Okay.
Just a question. Data, no, there is no data for that strategy is just more from experience.
Okay. Any role of IVIG in treating fungal infection?
I think that has been asked me a few times. Unfortunately, data so far suggests no. It doesn't help in managing, because ultimately it's a macrophage dysfunction that leads to more invasive aspergillosis infection rather than to do with your immune surveillance from lack of immunoglobulins. So it doesn't necessarily help. Of course, if you have systemic soft tissue type infections, which are very difficult in patients heavily immunocompromised, secondary bacterial infections often are the major concern in these patients. So IVIG in those settings can help, even if you have an underlying fungal infection going on, but not just for fungal disease. We don't tend to give IVIG, and again, limited supply, that means we can't anyway. So there's no data, unfortunately, for that.
Okay. We can see here. So which antifungal you recommend in transplanted patient? Let me just ask you this question. It's a common scenario for all hematologists, I think. Patient acute leukemia develop fungal infections. Then you want the most important question: when to start next round of chemotherapy, or if this patient is going for allogeneic stem cell transplant, you should wait for how long before starting the chemotherapy or the conditioning?
If they had a fungal disease, you mean?
Yes.
I think that is a challenge, certainly in many settings. I think it very much depends, again, the type of AML, for example, they have. If they have a standard risk AML and you've achieved a response with the first course, then you potentially has a bit of a time to try and wait for the fungal disease to improve with neutropenia recovery, for example, and then consider going for the second line. We have had a lot of instances when we have high-risk disease and the patient is refractory to the first line, have already got a fungal disease. What do you do? And in those settings, we just press on, because you do need the good neutrophils out to fill in that gap. And we carry on treating aggressively by antifungal agents in the meantime. The risk is high of them dying as a result, because we're going to just make them more neutropenic for another 3 to 4 weeks. but because of refractory disease, it's unlikely they'll recover anyway. So that's the only choice we have. So we press on in those patients. But if there is a gap between the transplant time, which often there is, you often wait to treat the fungal disease properly, reevaluate to make sure that fungal disease has gone by repeat CT scans and biomarker testing. We often give them secondary prophylaxis prior to coming to the transplant because the risk period is high, especially we do know with the data published in our cohort as well as in other studies that the risk of developing fungal disease post-transplant, if you had a previous fungal disease, is around 3 times the standard risk. So we tend to generally give them secondary prophylaxis to tide through that waiting time until they start the transplant, and then carry on that prophylaxis until they recover their neutrophils, and then go back to standard sort of prophylaxis. So that's how we've been doing in the recent fungal disease elements. But in terms of pressing on with next round of chemotherapy or your conditioning, very much depends on the risk profile of that patient from an underlying disease point of view, and that's how we approach it.
Okay. Well, there is one question from the audience. Which antifungal you recommend as a prophylaxis in transplant setting?
Good question. I think that is, again, depending on if it's an autograft or setting only, that you don't have more allogenic group of patients, then we don't necessarily tend to use triazoles. We tend to just use fluconazole for the period of the neutropenia only. For autografts, again, some centers don't even give any. They just use diagnostics and then don't give prophylaxis. We tend to use prophylaxis for autografts who have had significant significant treatment burden, previous heavily treated patients, or have had a fungal disease. We tend to then give them prophylaxis, considering them as a potentially higher risk. In the allogenic program, triazoles as a prophylaxis is recommended, especially if you don't have access to good diagnostics in a time-bound manner. So usually posaconazole has the best evidence in that setting. Is both European guidelines as well as IDSA guidelines suggest posaconazole has a good evidence for prophylaxis in neutropenic as well as for GVHD settings in transplants. And that's what we currently use. Some centers do use itraconazole, but I think the toxicity of it can be quite challenging, and you still have to start thinking about therapeutic drug monitoring and interactions with cyclosporin and so on, which again is a bit tricky to manage. So we tend to use posaconazole tablets for our settings for high-risk patients itself. But autografts, you probably don't need to. Fluconazole might just be enough.
So question regarding once the patient documented to have a fungal infections, how frequent you repeat the CT chest?
Yeah, so I think that is again, so the two scenarios. One is that if the patient had some size of fungal disease radiologically and you treated it, then you really need to treat it for at least 14 days and see how the response clinically is. You wouldn't necessarily repeat the CT at that time. You probably want to repeat the CT at the 4-week point after you start therapy, because that's how long it takes for the resolution of these infections. If you do it too soon, often you will see that the lesions actually grow bigger, which is just a marker of their response to antifungal therapy. They become more edematous in that area. They tend to look bigger. So often you will then think it's progressive disease and you probably want to change therapy, which is incorrect. So if they're clinically responding, you will probably do it in 4 weeks, even after you've stopped therapies in 2 weeks' time. If they're not clinically responding, they're still persistently unwell and febrile, I tend to do a repeat CT in about 7 to 10 days' time after starting antifungal therapy to see what's going on. If they've got much more progression of disease than just accounted for the edema that we normally see, then you probably want to add in or switch to a different antifungal altogether. And that's for patients who are persistently biomarker positive or have worsening clinical symptoms. And that's when I do CTs a bit sooner. And often I kind of then go towards doing a PET scan, because often there is a concern that even if you do a CT, the lesions may look bigger or positive, but they actually may be scar tissue or just infarcted tissue. So PET CT in those settings may help you understand if there is a progression of disease and lighting up areas in other areas, which may suggest that is more disseminated than we think, and we then add in a second antifungal in those patients. But that is a rare scenario. We tend to kind of go with biomarkers and the clinical improvement in these patients to decide when to do these early interventions. But generally, recommendation is 4 weeks is the minimum you would need before you look at radiological changes.
Okay, good. So a question regarding lactoman test. So do you do it peripherally from the blood, or do you prefer to do it like from BAL?
I think both, especially if you're doing prophylaxis approach for triazoles, the blood lactomannan may not be, quite strong in terms of the sensitivity, and you may not be able to rely on the test because you often do see falsely negative biomarkers in the triazole settings. So we tend to obviously do combination approaches, CT as well as PCR in the blood. If the CT is got abnormalities, we then definitely get a bronch and a galactomannan in the bronch, because that option is more sensitive, even if we have prophylaxis. But certainly kind of, if it is positive in any of these, you certainly would like to treat straight away. So we tend to use a combination approach, try and get a bronch in as well as a serum approach, but we don't rely on serum negativity whatsoever. We don't say that it is negative, which means you don't have fungal infection. It's only have negative CT and repeated negative biomarkers, then you would think it as unlikely to be a fungal disease, and you can just carry on with prophylaxis. But yeah.
And if it's positive from the serum, would you do that as another galactoman as a follow-up, or?
We do. So that is important. So if you have a positive first, we always should repeat within 24 hours the next one to make sure it's not a falsely positive one. And if those two are positive or rising, then clearly is a very good signal of hyphae formation and invasive fungal disease in these patients. So clearly need to be treating it. And often you would see that the BAL becomes positive first before the serum becomes positive. So we try and get the BAL as quickly as we can when we do see radiological changes. And then we often see the serum following suit a week or two later, especially in very sick immunocompromised patients. So it's important to repeat it and looking for other fluid areas where you might think that there is a fungal disease. And that's what we do, especially if you have a CNS disease, you want to do a CSF galactomannan to make sure there is positivity there or not, to pick up that infection. So we tend to try and look at other fluids too.
Okay, so just a question from one of the audience. Is exposure to repeated CT radiation may increase the risk of fungal infection?
I think increased CT radiation definitely is a worry for any of the infection imaging we do or disease imaging we do. The protocol that we use in our center is a low-dose CT protocol, non-contrast CT surveillance that we use, which means the risk of having radiation-related toxicity is significantly less compared to traditional methods like HRCT or a full dose chest CT that are traditionally done. So we on purpose have obviously are using low dose CT, which is quite good and still pick up all these infections and has a low risk of radiation toxicity. Does it increase your risk of fungal disease? As unlikely. In my view, there is no data to suggest that. And I think we've been working with one of the world expert radiologists in our center who've been doing these CTs for many years. And each time he sends us a report with how much CT radiation this patient had and tells me the long-term risk of radiation toxicity for each scan he does. But with all that experience, we haven't seen, despite that, any increased risk of fungal disease. Often is because of underlying disease as well as patient factors rather than radiation-related toxicity. But certainly you have to be mindful about when to do CT scans, not to do it too soon or too late, and have to be kept in the context of clinical improvements or justified in that way. So that is a concern that we have to kind of keep in mind, especially in young females and children, for example.
Okay, so one last question, and kind of hear your comment. So one of the audience said, if we choose antifungal drug according to underlying unique pathology of each immune compromised disease, can this increase the efficacy and reduce the side effect?
I think perfect. I think that will be the ideal scenario, gold standard approach. You kind of personalize your antifungal approach to the type of patient and the disease he's suffering from, and at the same time looking at other medications and therapies we are given to that patient. So certainly that will be the ideal scenario. But that is limited because we don't have many classes of drugs. We are limited within 3 classes of drugs. If you've been using one already for prophylaxis, then you're only left with 2 classes of drugs for treatments. And then at the same time, then you have to kind of also look at interactions between those classes of drugs. So you have to kind of think hard about which drug is got best evidence, less toxicity, more efficacy, and what type of disease area you're treating. Traditionally, high-risk disease and high-efficacy drugs, like posaconazole or isavuconazole, even ambisome, are traditionally the reserved drugs that we use for treatment purposes, if you're not using any prophylaxis, for example. But if we are using prophylaxis, then the choice is mainly between echinocandins and the ambisome. And echinocandins is usually as a salvage or a second-line treatment for us. So that's kind of how we approach this scenario. But ideally, you would now want to know some ways of risk identifying these patients, what drug will work best for that drug, for that fungal disease, and pick up those fungal disease in terms of PCR monitoring to look at resistance screening that will identify which drug is more suitable. And that's the future we're looking at. But it will also mean more research and more resources and allowing this knowledge and access to these diagnostics widely, because not all centers have access to this. And that is a struggle in current scenario that we are dealing with. So I'm hoping, with that sort of continual dialogue and education that we're doing today, to be able to talk among us and improve the algorithm that we want to use together, getting together to get a diagnostic service that we can all, have access to improve patient care. And that's the only way forward, basically, in my view.
Okay, thanks, Dr. Varun. I think we are reached the time now. So thanks a lot for your presentation. It was actually informative and reflect real life scenarios. And also thanks for our sponsor today, Gilead, for this presentation. And I want to thank Dr. Asker and SSBMT for organizing this webinar. And just to remind you about next week webinar about diagnostic approach to myeloid neoplasm using NGS by Dr. Saeed Turki. Thank you and bye.
Thank you very much. Thank you for having me.
Thanks. Okay. Bye.
Thank you.
Good evening.
Great. Thanks.
Bye.
Thank you, Dr. Asker.